Good afternoon, and welcome to this 200th year bicentennial event for the School of Medicine and Health Sciences, Harnessing the Immune System Against Cancer, from Shots to Stem Cells. First, I would like to welcome and appreciate our special guests, Drs. Jay and Julie Katzen and Millard Bennett, who are members of the board of the Katzen Cancer Research Center, and it is through this philanthropic gift from Dr. Cy Katzen that we have that has enabled GW Cancer Center's advances in the immunotherapy space we're going to talk about today. So the School of Medicine and Health Sciences is turning 200 years old. It was founded in 1824. And in honor and celebration of 200 years of training generations of exceptional physicians and scientists, the school has put together this series of bicentennial events to showcase our special talent and research as we steer into our third century. This series is going to close on March 30th, 2025, which was the very first lecture in, I want to get this right, in the medical department, which was what the school was known as in 1824. So we have a lot to celebrate. And without further ado, I would like to introduce myself and these panelists. I am Dr. Julie Bauman. I am the Dr. Cy Katzen director, family director of the George Washington University Cancer Center. Try fitting that on a business card. And very honored to hold that role. Sitting to my left is Dr. Rong Li. He is the chair of our Department of Biochemistry and Molecular Medicine, as well as the school's Ross Professor of Basic Science Research. He is a scientist who has focused his career and made multiple important discoveries on gene regulation, particularly in the context of breast cancer. He is going to be sharing with us today his lab's discovery of an immune shield, a way that cancer can hide from the immune system and its implications for drug development. Dr. Chalasani is a professor of medicine and the chief of hematology oncology here. She is a breast cancer medical oncologist with expertise in developmental therapeutics, that is, new medicines, and how we get our discoveries into our patients. So she will be sharing the use of engineered antibodies as medicines to activate the immune system against cancer. On her left is Dr. Amarendra Neppalli, an associate professor of medicine and director of the Adult Transplant and Cellular Therapy program here at GW Cancer Center. And he is going to discuss classical approaches to stem cell transplantation, which is the earliest form of immunotherapy in cancer medicine. And then on his left is Dr. Kath Bollard. She is the associate center director of GW Cancer Center for Translational Research and Innovation. She's a professor of pediatrics and directs the Center for Cancer and Immunology Research at Children's National. She is an internationally recognized clinician and scientist in pediatric stem cell transplantation and something called adoptive cell therapy. She's going to be sharing her innovative research where she re-engineers human immune cells into living medicines. So to begin our journey today, I want to tell a story. And the story begins with highlighting the marvelous nature of the human immune system and its capacity to be harnessed to fight cancer. So to introduce to you the cast of characters that will help us to understand the science and the clinical advances we're going to be talking about today. First of all, the villain. The villain is the tumor or the cancer cell. And this is that, enemy within our body, that foreign invader made from our very own cells that has become abnormal and turned into cancer. The superhero of this story is the T cell. That is our natural white blood cell in our bodies, can actually kill the tumor cell, can find it and destroy it. And then the third character is the professor. This is the antigen-presenting cell. This is the immune cell that teaches those T cells how to do their job, how to seek and destroy their villain. So every superhero in our body matches just one villain. And this is something absolutely extraordinary. There are literally billions of T cells in our body that have the potential to recognizing something abnormal about that tumor cell and to eliminate that villain. I call this the fateful handshake, when the T cell with that puzzle piece, a T cell receptor, binds to something abnormal on the tumor, an antigen. And what happens next is the superhero can then eliminate its match. So how does the villain hide? For a cancer to be successful in the human body, it must evade the immune system. It must hide from the superheroes. So first to talk about is the immune shield. So Dr. Rong Li has discovered a literal physical shield that cancer can use to hide from the superheroes. And I want to just play this animation, Dr. Li, to show that the tumor can hide what's abnormal about it from the T cell to avoid that fateful handshake. So Dr. Li, can you please describe your lab's discovery of an immune shield and how that works?
Sure. First of all, thank you so much for including me in this wonderful event. So as you all know, cancer can be viewed as a tug of war between the good guys and the bad guys. Mm-hmm. And so for the bad guys to evade elimination by the good guys, they can create a whole lot of gimmicks there. One of the gimmicks is to set up a physical shield that prevents immune cells from even coming into tumors. So we call it immune exclusion there. So my lab have been working to address three fundamental questions regarding immune exclusion. Number one, what is the biochemical nature of this physical shield? Mm-hmm. And we found that it turns out collagen fibers is a major constituent of this physical shield. Question number two, how do tumor cells instigate to orchestrate this buildup of physical shield? And what we found is that there is a collagen receptor that tumor cells express on the surface of tumor cells. And that receptor plays a very important role in erecting this physical barrier that prevent immune cells from coming in to tumors. And the last question that we address is that, well, knowing all this, can we find a way to break down that physical shield? Mm-hmm. And what we developed is a neutralizing antibody that specifically recognizes the receptor on the tumor surface. And at least in preclinical models, this antibody can significantly impair the physical shield. And so to sort of lift the floodgate mm-hmm. for the immune cells to come in and kill the tumor cells. So this antibody is now being tested in phase 1 clinical trial involving cancer patients with different types of solid tumors.
Wow. So this is an antibody drug that would literally prevent the assembly of the physical shield. that keeps T cells out of the tumor.
Correct.
So what do you see as the future of therapies that could break down the shield? What other kinds of shields do tumors make?
Well, what we found is that this so-called collagen receptor is only one player in a huge network that tumor cells mobilize to set up this effective barbed wire, so to speak. So using the knowledge that we acquire from the first phase of our study, we're now doing genetic approaches or pharmacological approach as well to identify individual players that basically work with the first player that we identified. The hope is that we can develop different antibodies to neutralize individual players in this whole network.
Very interesting. So, and that moves us to a new topic. So thank you so much for sharing those early insights. Laboratory discovery that leads to the development of a drug that could be used to activate the immune system. First, a drug that could break down the immune shield that excludes T cells. So our next speaker, Dr. Chalasani, is going to give an overview of the role of antibodies in immunotherapy for cancer. But before we start with questions, let me tell a little bit more of the story. Let's get deeper into the anatomy of this T cell. So you saw the T cell receptor is that puzzle piece, but there happen to be other receptors on the T cell that can rev up the superpower and its ability to eliminate that villain when that T cell finds the match. And that is like stepping on the gas. Then there is also a brake on the T cell that weakens the superpower. And this is very natural because in our body's immune system, we need a way to shut down the immune response when we're done getting rid of the virus, when we're done eliminating a foreign invader, the bacteria. So it's natural to have this ability to down-modulate that T cell. However, when that brake is pressed, you see that the T cell is exhausted and goes to sleep. And that is something that cancer can exploit. So the villain actually reaches its ugly foot out and steps on the brake of its matching T cell. This is a process called PD-L1, matching to the PD-1 brake on the T cell. So this villain is actually putting that T cell to sleep. We have learned, and the huge wave of immunotherapy that has gotten so much press and advanced the field so much in the last decade is an antibody drug that blocks that interaction between the villain's foot and the brake on the T cell. So takes that foot off the brake and allows the fateful handshake. So, Dr. Chalasani, you have done a lot of clinical research with antibodies, which are medicines to treat cancer. How do these medications work?
Yeah. So I think the cartoon is like amazing in that inspection. So we have medications, like the antibodies which are engineered, one which directly go and take off the brakes. I mean, I would say the pressure off the brakes. So that way, this foot doesn't have anything to attach to. It cannot put it. So we have antibodies currently in clinic, which have been shown to develop and act against various types of cancers, and in both solid tumors and also in kind of different hematological cancers like lymphomas and other tumors right now, which are approved, which have shown that we can prevent the foot from stepping on the brake, and the other one is blocking the foot from coming out too. So we have both PD-1 blockers and PD-L1 blockers. They are used in combinations with chemotherapies at times and all, but we have those which are engineered and approved in clinic. So that is one way we have done that. And as Dr. Bauman has shown in the real cartoon, the superheroes, there are other ways that it can be activated. In addition to the brake and the gas pedal too, we have other ways we can activate the T cells, and those are also in development currently in clinical trials and show really good promise. So trying to attack and activate the superheroes in multiple ways, because cancer always tries to find a tricky way, another way to block it. So we have to try to be a step ahead in trying to prevent
Stay
it.
one step ahead of the villain. So this is really exciting. I also have seen immunotherapy transform my practice.
Yeah.
I'm curious, what are some of the side effects or limitations of this approach?
Yeah. So as we are trying to really rev up the superheroes, we might just really activate it a lot. So they are hyperactive and hypersensitive and looking out for these antigens or receptors so they can go and get the fateful handshake going. But as we make it super active, the concern, one of the side effect profile that we kind of see it in clinic is the fateful handshake, it can attach and start activating on some of our normal tissues. That is where one of the mechanisms of how autoimmune diseases develop is where our immune system is attacking our own internal organs, not recognizing this is healthy tissue and it's not supposed to do that. So that imbalance between the brake and the gas is it's activated. So the side effect profile ends up is when the immune system is so hypersensitive and super active, it doesn't recognize some of the things that is attacking or getting the handshake on is the healthy tissue. So autoimmune problems can happen. So essentially any organ is there, but most of the times it is the endocrine organ. So we frequently check in the clinic the thyroid, if there is any dysfunction of the thyroid. That is one of the early ways we can pick up. But it can have skin rash, it can attack the gut, it can essentially attack because it's our own immune system, so there's no kind of barrier. So, but that is the flip side and the side effects that we try to intervene and see if we can pick it up before it's happening.
Wow. So what do you see then as the future of antibody drugs? And I wanted to say one quick thing. Antibodies, we all recognize. We make antibodies against viruses. That's one of the ways that we mount a response to a vaccine. So antibodies are proteins that our own immune systems make to fight infection. And so engineered or drug antibodies are made in a lab in the shape of a human antibody to eliminate cancer, for example. So what do you see as the future of antibody drugs in cancer medicine?
Yeah, so antibody drug conjugates they're kind of also called as biomissiles. So what happens is we are, like I said, the cancer is trying to survive or things. So what these antibody drug conjugates are, we have the target which is expressed on the cancer cell. So there's an antibody engineered, there is a chemical link, and then there is a chemotherapy or the payload which is attached to it. So it is given IV, for now those are the drugs we have. It goes in, looks for the receptors. It's mostly on the cancer cells. Even if there's a little bit of receptor, some of these antibodies have really high attachment, affinity for those receptors. They go in, they're taken inside, the link is broken inside, and this chemotherapy or the payload we have, which is attached to it, is released inside the cancer cells. Very targeted way of delivering treatments that we weren't able to use before because we just could not get enough drug without it making really strong for the patient. It's very hard. But now we are able to deliver it very targeted to that. So that's the antibody drug conjugates, which are the new ones. The first one was approved over a decade ago, but now we have 140 in development. So it's just taken off and has shown really good effect. And that means one of the things they do by immunotherapy is when they go and kill the cancer cells, they release this proteins and other newer ways that we can recognize. So the professor comes in, recognizing all those things and going around and teaching the superhero new ways. These are the new ones which are coming up on the cancer cells. So
you're foreshadowing. Yeah, we'll talk about that really exciting way
in terms of how things go.
Finding more puzzle pieces, creating more superheroes to match
those
the villain. All right. Really exciting movement, and as you've heard, there are immunotherapy antibodies in the clinic right now that are advancing and helping many patients live with their cancers and in many cases be cured. I would now like to return to our story and talk about the very first cell therapy in medicine, which is bone marrow transplant or stem cell transplantation. And I have an animation for this as well. So first, this is a person who's afflicted with a tumor, often, for example, leukemia or myeloma, a blood-based cancer, where the villains and the superheroes are literally throughout the body. And so in order to treat this cancer, more than 50 years ago, this method was developed where first we collect from the body for safekeeping the superheroes. So in this bag, we have cells that have been removed from the patient, and we put those aside for safekeeping. Then we administer high-dose chemotherapy to eradicate the villain. And if we were to not have removed the superheroes for safekeeping, that high-dose chemotherapy would eliminate the immune system, and this person would not be able to get well. So this is one of the early ways that now we restore this safely kept, banked superheroes, the bone marrow or the stem cells, and give them back to the patient so their immune system can reconstitute. And earlier today, we just came from an event celebrating the opening, the launching of our cell therapy facility here at George Washington University School of Medicine and Health Sciences, where we have collected, processed, and given back the stem cells of patients now within our own walls. So here with us today is Dr. Neppalli. Can you share some of the basics of stem cell transplant?
First of all, thank you, Dr. Bauman. I think the cartoon simplified many steps to understand what are the steps in the transplant. To give you an insight, there are roughly about 20,000 transplants done every year currently in the United States. And it could be broadly classified into whether those stem cells are coming from patient or they're coming from a healthy donor. When we collect from the patient, it's called autologous stem cell transplant, and that's what gives us the capacity to give high-dose chemotherapy safely so that we can recover their immune system with the stem cells that are stored. And the second one is the allogeneic, where we collect those stem cells from the healthy donors. However, the complexity involved in an allogeneic transplant is going to be much more complicated, balancing the immune system of a healthy donor. The autologous transplant is usually about half of all the transplants done in the United States. So it's quite commonly done, and one of the major indication is multiple myeloma, and that's what we treat here quite often at GW. Once we identify a patient who would benefit from the treatment, the first step is to make sure they're safe to receive that high-dose chemotherapy. We check their critical organ function, their heart, their lungs, various infection markers, and once we deem it safe to receive that high-dose chemotherapy, we collect those stem cells as an outpatient and then give the chemotherapy, and it usually takes about 2 to 3 weeks intense side effect period where we support them, and the recovery process is roughly about few weeks, 3 to 4 weeks. Overall, it's a safe process with mortality from the transplant itself being less than 1%, which gives us the opportunity to have a very good control of the disease. And the second aspect of the transplant is allogeneic, where I could speak for hours about what are the advances, but To kind of lay highlight on what are the significant advances, one thing comes to my mind: presence of an eligible donor. If we don't have an eligible donor, we cannot do allotransplant. And as we all know, blood typing, ABO, when we look for a donor, it's not the blood typing, but it's the immune system typing called HLA typing. And it has gotten significantly better over the last 2 decades. And roughly there are about 40 million donors available through different donor networks. Even then, the chances of finding a donor for a non-Caucasian patient is less than 50%. And I think in that aspect, haplotransplant, where a kid or a parent could be a donor, has significantly improved the odds, and also many other safety improvements over the last 60 years with the first transplant done in 1957. The outcomes have gotten significantly better. The tolerability has been significantly better. Finally, the access is also getting better. That's the general overview of transplant.
Thank you. And so this new cell therapy facility that we celebrated earlier today, how is that changing practice here at GW?
It is critical to highlight the access. While this has been there for more than 60 years, still many patients who require will not be able to get the treatment, and for a variety of reasons, whether it's a patient or institution. Our institution right now gives the access and the ability to give for patients we see in clinic without any limitations. That's the first step. The second step is to improve the teaching, the research components, where we are working with the different components of the transplant to make it better than what it already is.
Very exciting advances. So it's fascinating to think that bone marrow or stem cell transplant has been the first immunotherapy, the first living cell therapy for 60 years now. And returning to our story, I will be introducing Dr. Bollard, where we are now taking these natural T cells or stem cells, removing them from the body and actually re-engineering them. So you see here a T cell that was the wrong shape. Its receptor didn't match that villain. It had a brake pedal. And this T cell that has been re-engineered now matches the villain. It has a gas pedal in the on position. There's no brake pedal. So this is some of the theoretical underpinning of engineering cell therapy. So it's not returning the same cell to the body, but it's actually returning a re-engineered cell to the body. So Dr. Bollard, how have you transformed cells into therapies for patients?
So thank you, Julie, for that loaded question. For full disclosure, you're always meant to start with the disclosure statements. When I started as a postdoc 24 years ago in this field, I was in a lab that said that B cells, which is where antibodies come from, B stood for boring, and T stood for terrific. So I just want to, that's my disclosure. Sorry, Norm, about that one. So T-cell therapies, if you think about it, as we age, one of the reasons why we're more susceptible to virus infections, virus reactivations, and cancer is because our immune system is weaker. And the part of the immune system that gets weak is your T cells. So your T cells are your best guardian against viral reactivation and also protecting you from get cancer. So all the time, our body has our T cells surveying our body for stray cells that may become into cancer cells and is recognizing them and killing them. So when I first started in this field, I was really about trying to harness those cells. How in the laboratory could we pull out those cells, those T cells that we know we all possess that are cancer killing? And so currently at GW, I see Dr. Sweeney's here. We and others are really trying to make the best cancer-killing T cell that we can to target solid tumors, liquid cancers, etc. And we have multiple ongoing clinical trials in adults and pediatrics to see how these cells work and if they can prevent relapse in our highest risk patient population. When you talk about engineering, we're also doing that too. And engineering is a way to really make your T cell even more terrific superhero, that is for sure. And so there I have to bring it back up that we're actually utilizing the antibody, but we're making these receptors where you take a piece of the antibody piece that recognizes the villain, the cancer cell, and you engineer it so it's got the antibody recognition piece, so it can recognize like an antibody, and then the T cell machinery down the bottom. So now this artificial receptor, which you put into your terrific T cell, makes that T cell even more terrific because it can now recognize the tumor like an antibody would, but kills it like a T cell. So this has been really revolutionary to the field. I was lucky enough to serve on the ODAC with the FDA that approved the first, we call it CAR, chimeric antigen receptor, T-cell technology. This was a therapy for children with B-cell ALL and has now really changed the field in adult lymphoma and myeloma. And in many situations, we are now looking at strategies where we use these CAR T cells as almost frontline before we would use transplant. So this has really been a game changer, and certainly for blood cancers, for so-called B-cell blood cancers, it has really been a game changer. I think there is still a lot of work to be done in the field, especially for solid tumors and for some types of leukemia, certainly the type of leukemia that affects adults mostly. So there is still work to be done, but there's a lot of activity going on here as well as nationally and internationally.
So you've talked about terrific T cells and boring B cells. What other,
Don't quote me on that.
what other kinds of cells could be engineered to fight cancer?
So there are these other cells called natural killer cells or NK cells, and they are, by their name, natural killer cells. The advantage of them is that they are actually very easy to expand from anybody's peripheral blood, actually. They don't cause what we call graft versus host disease, which is where if you put in foreign cells, like in bone marrow transplant, you can cause attack of the patient's healthy cells.
Like an autoimmune complication.
Correct. And natural killer cells don't do that. So they are also a natural defense against viruses and cancer and can be harnessed in certain situations. And so here at GW and our cell therapy program that we have with children's, obviously, is also looking at trying to engineer those cells with the chimeric antigen receptor, or the CARs that I was talking about, that can. And the advantage of that is they can be given like a drug off the shelf. You don't have to make one product for each individual patient. One product can treat multiple patients. So this is a very exciting time for our field, I have to say. So, yeah.
Indeed, it really is. And We are talking about cancer today, and this is where many of these strategies have been developed both here at GW and across the world. Are there other diseases where cell therapy could be relevant?
So I think what's really exciting in the field at the moment, the CAR T cells that have been approved by the FDA for leukemia and lymphoma, like I talked about, these so-called CD19 CAR T cells, have now been used in Europe and in the US in clinical trials to successfully treat several autoimmune diseases. And this is really an exciting space to watch, because if we could cure people of their autoimmune diseases so they don't have to take these immune suppressive medicines for the rest of their lives, that would be life-changing for many of these patients.
So these are diseases, autoimmune diseases are like lupus or
rheumatoid arthritis, myositis, which is inflammation of your muscles, really debilitating diseases that, while might not be as life-threatening as cancer, severely impact the quality of life. So, yeah.
Really exciting. So now I would like to return to our story after thanking this amazing panel of experts for really bringing to life some of the newer immune therapies. I want to talk now about I'm having a non-advancement issue.
So you've got it.
Oh! It came along. It woke up. The T cell woke up. So I would like to talk now about a new form of immunotherapy called the personalized cancer vaccine. This is, I'm going to allude back to what Dr. Chalasani was talking about. How do we create a broader pool of superheroes that recognize a tumor and recognize the tumor and not the normal tissues of the body? So this is the basis of what's called a personalized cancer vaccine. First, we run the tumor cell through a decoder. It's called next generation sequencing, where we identify the things that at the DNA level that are abnormal, the mutations of that cancer cell as opposed to the normal cells of the body. These mutations are like the puzzle pieces that T cells could recognize. They're new matches for new superheroes. Then we take those mutations and we load them via mRNA into a vaccine, into a shot that is given to a human being. So their cancer has been decoded. The mutations in their cancer have been identified, and those mutations are now presented to that person's immune system in the form of this shot. And what happens is that this vaccine sends the T cells to school. The professor, the antigen-presenting cell, takes all of those puzzle pieces and shows them to the baby T cells. And the baby T cells learn what puzzle piece, what they are supposed to recognize and eliminate. And we get an army of tumor-specific superheroes. So this is happening inside the patient's own body. So we've heard about removing the T cells or the NK cells or the B cells, re-engineering them or using them for safekeeping in the setting of a transplant. In this setting, we're giving a vaccine that teaches the immune system in the body what it's supposed to seek out and eliminate. So in principle, now we have many more matches against that individual's cancer, and therefore many more fateful handshakes where the villain cannot hide. So that is our scientific program. Now, I want to introduce a very special guest. Thank you. I would like to introduce Molly Cassidy. She is a patient of mine who I first met in 2018 when she was diagnosed with head and neck cancer, a form of cancer that affects the lining of the mouth and throat and deeply affects really crucial human functions like breathing and swallowing and speaking, facial expression. So she was finishing her third year of law school at the time and nursing her baby when I first met her. And she is here to tell us her story about being treated on an immunotherapy clinical trial. So Molly, thank you so much for coming today to share your story. Can you please tell us about the start of your journey?
Yeah, thank you for having me. So as Dr. Bauman said, I was diagnosed with stage 4 oral squamous cell carcinoma, which as a head and neck cancer had the potential to be extremely debilitating. So I was really faced with some pretty big fears of possible facial disfiguration, affecting my ability to speak, swallow, eat, and drink. I had no risk factors when I was diagnosed with cancer. I was a healthy 35-year-old woman, and it was a very beautiful time in my life. I was a brand new mom to a sweet baby boy. I was getting married, buying a new house, just about to take the attorney bar exam, and graduating from law school. So I should have been celebrating all of that beauty, and instead I was giving the most devastating news. I had cancer. Initially, I received standard but intensive treatment with a curative intent. I had a partial glossectomy where part of my tongue was removed. I had a neck dissection where I was cut from my earlobe down to the middle of my neck. I had 34 lymph nodes removed because my cancer had spread into my neck. I had a skin graft taken from my thigh and placed on the floor of my mouth. A GI tube put in so that I could eat and drink. After surgery, I received 35 radiation treatments and simultaneous high-dose chemotherapy. Radiation caused me to burn very, very badly on my neck. It was difficult to eat and swallow. I lost some of my hair from the radiation. And the chemo caused me to be sick after each dose. That cancer treatment was one of the most physically, mentally, and emotionally challenging things I've ever done in my life. But after I did treatment, I rang the bell, and I was ready to walk away. My husband kept telling me, this is just going to be a little blip in your life, and we're going to move on very quickly.
So there you were, you had finished grueling cancer treatment and rung the bell. And as you said, it was for curative intent. I remember those days. Mm-hmm. So then what happened? What changed after that?
I had just finished treatment, and as I said, my neck was very badly burned, so I was putting on some cream to help with those side effects. And I found another tumor. And at that point in time, my treatment options were quite limited. But I qualified for a clinical trial where they removed that tumor that I had found and made a personalized mRNA vaccine from it. And I was going to be injected with that personalized vaccine and have pembrolizumab, an infusion with it every 3 weeks. But I was becoming very, very sick very, very quickly. My cancer spread rapidly throughout my mouth, into my neck, and then into my lungs. You could see tumors protruding from under my skin, which were bigger than the size of a marble. I remember that you were very optimistic about the clinical trial, but also compassionately and sincerely told me to get my affairs in order. So I faced my own mortality. I went to an attorney and I wrote my will and my trust. Then I went home and I wrote my son 35 birthday cards. And a letter for every special occasion that I was gonna miss. His first day of kindergarten, getting his license, when he graduated high school, when he graduated from college, when he got married, when he had his own baby. And then I wrote him a journal about my life so he would know his mom. And I sat my parents down at my brand new kitchen table in my brand new house, and I gave them my will, and I told my husband I wanted to be cremated. I had about another 65 weeks of treatment and CT imaging every couple months so that they knew if this personalized vaccine was working. And by the grace of some higher power and really good medicine, each and every single scan showed my tumors getting smaller and smaller, and then fewer and fewer. And then I had no evidence of disease. And that was almost 4 years ago today. I'm so grateful for this cancer research, for you, of course, Dr. Bauman. But the research that you all are doing here gave me the gift of time, gave me the time to live the beautiful life I had created. So thank you.
Wow. Wow. Wow, Molly. Thank you so much for your vulnerability and the power of your words. You are living evidence of how science and good medicine and compassion and focusing your life on what truly matters is transformational. So thank you so much for trusting me with your care, trusting really good research and a clinical trial. This is the very first in human clinical trial of a personalized cancer vaccine. So I'm speechless. And Molly, like, you are the reason, this is the reason why we get out of bed every day. This is the reason why we do what we do. So thank you so much for sharing your story and the power of your words. And I think you told me yesterday that your son, Brogan, is now in first grade.
He's in first
So
grade.
you were there for that kindergarten, first
Yeah.
day of kindergarten, and then some. Wonderful. So now here at the GW Cancer Center, we are actively conducting this same personalized cancer vaccine. We've learned a lot since 7 years ago. And we are now testing a similar approach in different kinds of cancer, including pancreatic, stomach, and lung cancer, and particularly in patients who have been treated with curative intent but have a very high risk of their cancer coming back, and see if we can give them some extra superheroes. We've just opened our new cell therapy facility, and they've had one at Children's to support Dr. Bollard's team. And we now have this capacity to create new engineered living cells in a facility in Ross Hall. So with that, with my thanks to the panel for the steadfast work that you do every day, even some days where science falters and we don't get the results we want in the lab or in the patients where it really matters. Thank you for your dedication to this field. It's truly a remarkable time in cancer medicine. And in the next 10 years, I think we will look back with awe at the progress that is made, that is finally reaching patients, where there are many, many more Mollys to tell their story. Thank you to the Katzens for the original endowed gift for the Katzen Cancer Research Center, which has enabled the power of what I now call the last mile, bringing our discoveries to our patients to really transform their lives and to change the face of cancer in the DMV and beyond. Thank you very much. Because we still have a few minutes until 1 o'clock. If anybody would like to ask a question of any of the panelists, we would welcome them.
May I ask a stupid question?
Of course.
I saw the stupid cancer mug here. Why is there cancer? What? Those are our own cells. Is this just something that humanity has always had, and we used to die on average a lot sooner? We're living a lot longer on average now. And is this a natural process, or is it a cell that becomes immortal or quasi-immortal and doesn't die? I mean, when we're in the womb, the tissue between our fingers dies, it goes away, and we end up with these fingers instead of what other animals have, maybe. But why is there cancer?
So I'll answer a little bit at a conceptual scientific level and not a teleologic level. Cancer is fundamentally about one of our own cells where the code, the very DNA, gathers mutations that results in it being misprogrammed and immortalized, just as you suggested. And those mutations come from a variety of sources. Some of that is from environmental carcinogens that we understand, unfortunately, more and more about, and there are more and more of them in our environment since industrialization. Some of them, mutations happen every single day in every single cell, but they're repaired. But over time, as our immune systems age, as our cellular mechanisms age, we become less able to repair mutations that we ordinarily would. So we get more and more mutations in cells that aren't repaired. And at some point, that cumulative number of mutations in a cell, a normal cell that started as a normal lung cell, a normal tongue cell, gains that immortalized ability to make copies of itself, where one cell becomes 2, becomes 4, becomes 8, becomes a tumor, and then gains that ability to travel and go to other parts of the body. So it's an accumulation of mutations and that ability to hide from the immune system that are 2 fundamental hallmarks of cancer. Yes.
I wanted to first thank all the panelists. This is amazing. This question is for Molly. And specifically, thank you so much for sharing your story. It was incredible, very touching. Where did you find the strength to write those letters and do all of those things and then go back and pursue treatment?
My son. I mean, it's just that I wanted so badly to be a mom, and then I was finally a mom, and it felt like that was slipping through my fingers. And I couldn't imagine what his life was going to be like without me. And I wanted him to feel the love that I had for him. And he was really the driving force of what made me make those choices, but also show up every time for those treatments.
Thank you so much to all of you for this awesome presentation. If cancer is not scary enough, the idea of chemotherapy is pretty scary to all of us. Am I correct in assuming that these newer therapies do not carry the same side effects as what we have traditionally thought of when we think about chemotherapy?
So they definitely have different side effects. Chemotherapy has got a lot of stereotypes, and though we've gotten better at supportive care for high-dose chemotherapy and helping people to survive that difficulty with nausea medicines and medicines to boost up white blood cells and prevent infection, they still carry a lot of risk and a lot of wear and tear on the body. The immune system is almost like the opposite. The immune therapies can cause these autoimmune side effects where a hyperimmune system attacks the wrong thing. The wrong T cell wakes up at the wrong time. So as we gain in scientific knowledge, what we're learning how to do is wake up the right T cells at the right time in the right place so that they're through the immune shield and they're engineered to have a more specific target, or they've been introduced through the T cell school. So we have a lot, as we get more specific and make more superheroes that match exactly the cancer, I think we're going to see fewer and fewer side effects. I think another person who could help us with that question is Molly. So Molly, what side effects did you experience on the vaccine trial?
Initially, when I got the immune therapy treatment, I had been injected with the vaccine as well. And so my arms were pretty sore, but it wasn't anything more sore than what a flu vaccine was. And then I had a fever for a day or a day and a half, maybe at the most 2 days. Initially, my fevers were quite high when I started treatment, but then it became more tolerable as I progressed through treatment. And when I had my first NED scan, I also started developing an autoimmune response that caused some numbness throughout my hand, up my arm, and in part of my diaphragm. But it thankfully coincided with an NED response. And I remember Dr. Bauman saying, we're looking at a quality of life issue, so you cannot have a partially paralyzed diaphragm. And so we looked at, ceasing treatment and treating some of the autoimmune immune response. But thankfully, I was also having that first clean scan.
So she developed an autoimmune response against her nerves that resulted in my having to stop the treatment, but also to treat her with prednisone, a steroid to calm her body's immune system down. Thankfully, we were able to stop that autoimmune problem, and she didn't get progressive paralysis or that kind of a situation. And she stuck the landing, and her immune system still carried on its really good work of eliminating the cancer.
Do you have time for more?
Sure.
Thank you, Dr. Bauman, and thank you, panel. Simple question. Does metabolism cause any cancer or cure any cancer?
I think Dr. Li, you have some work in this space. How would you like to take that one?
Right. So metabolism has a lot to do with cancer initiation, progression, and treatment. It's going to be a 2-hour lecture if I go into that. But the short answer is yes. And so related to that, our diet, nutrition, and gut microbiome, for example, have a lot to do with cancer progression treatment. So Dr. Chalasani and my group just initiated a collaboration to study how gut microbiome can influence the efficacy of cancer treatment.
So that's the bacteria that live in our own intestines, the microbiome. Interacts with metabolism and the initiation and progression of cancer, as well as our potential to respond to immunotherapy.
Stay tuned.
Yes.
Which probiotic should we be taking?
Thanks again for your kind attention and enjoying this really special event in celebration of the 200th year of the medical school.